On the afternoon of June 25, 2009, a team of paramedics arrived at a mansion on North Carrollwood Drive in Los Angeles and found a 50-year-old man in cardiac arrest. What followed over the next several hours produced a forensic record that is among the most detailed ever compiled around the death of a public figure. Autopsy findings, toxicology reports, court testimony from medical experts, crime scene documentation, witness accounts cross-examined under oath. And yet for 15 years, the public conversation about what happened in that bedroom has been dominated not by the forensic record, but by speculation, mythology, and the specific kind of rumor that attaches itself to the deaths of people who meant something profound to the world. Today, we are going into the actual forensic record, the medical evidence, the documented science, and we're going to examine the specific physiological anomalies that surrounded Michael Jackson, his final moments with the precision that the evidence deserves and that most coverage of this subject has never provided. Begin with the most important single document in the forensic record, the autopsy report completed by the Los Angeles County Department of Coroner following the official pronouncement of death at UCLA Medical Center at 2:26 in the afternoon on June 25, 2009. This document is the forensic foundation. Everything else in the analysis of what happened is interpreted in relation to what this report establishes. The official cause of death recorded in the autopsy report is acute propofol intoxication. The contributing factors documented include the presence of multiple benzodiazepine compounds in the system. The manner of death was classified as homicide, a forensic classification that in the context of medical causation means that the death resulted from the actions of another person rather than from natural causes, accident, or self-infliction. The classification does not by itself imply criminal intent, but the subsequent criminal proceedings established that the circumstances met the legal standard for involuntary manslaughter. The toxicology findings that supported the cause of death determination documented the presence of propofol at a blood concentration consistent with general anesthesia rather than with the sedation level that might be associated with clinical sleep induction. The specific concentration found was subsequently disputed in expert testimony during the Conrad Murray trial, with different experts offering different interpretations of what the propofol blood level indicated about the dose administered and the timing of its administration. The forensic significance of the propofol finding was not disputed. What was contested was the specific reconstruction of how that concentration came to be present. The benzodiazepines documented in the toxicology included lorazepam, midazolam, and diazepam. The presence of multiple benzodiazepines is significant for several reasons that the forensic record makes clear. Benzodiazepines are central nervous system depressants that enhance the activity of GABA receptors in the brain, producing sedation, muscle relaxation, and respiratory depression. When combined with propofol, which operates through a related but distinct mechanism of GABA receptor enhancement, the combined effect on respiratory function is synergistic rather than simply additive. The respiratory suppression produced by the combination exceeds what either agent would produce alone at the same individual doses. This pharmacological interaction is the first of the medical anomalies that the forensic record documents, and that requires careful analysis. The combination of propofol and multiple benzodiazepine compounds created a respiratory depression risk that was substantially higher than the risk associated with propofol alone. In a clinical setting, this combination would be managed through continuous monitoring of respiratory function, oxygen saturation, and cardiovascular status by personnel trained to recognize and respond to respiratory compromise. The absence of that monitoring infrastructure in the bedroom at Carrollwood Drive is what transformed a high-risk pharmacological situation into a fatal one. The question of why multiple benzodiazepines were present alongside propofol is answered by the timeline of events that Murray testified to during the criminal proceedings, and that was partially corroborated and partially challenged by other evidence presented at trial. Murray's account described a sequence of administration attempts across the overnight hours of June 24th into the morning of June 25th, in which he had attempted to induce sleep using benzodiazepines alone before eventually administering propofol when the benzodiazepine-only approach failed to produce the sleep that Michael Jackson required. The specific sequence Murray described involved lorazepam administered intravenously in the early morning hours, followed by midazolam, followed by additional lorazepam, followed by oral diazepam, followed by additional midazolam. The precise timing of each administration was central to the prosecution and defense arguments during the trial. The prosecution argued that the cumulative benzodiazepine burden in the system prior to the propofol administration created a physiological context in which the subsequent propofol administration was substantially more dangerous than it would have been in isolation. The forensic reconstruction of the final events is where the medical anomalies become most concentrated and most clinically significant. Murray's testimony established that he administered propofol at approximately 10:40 in the morning of June 25th. His account indicated that Michael Jackson fell into unconscious sedation relatively quickly following the administration, that Murray maintained observation for a period, and that he subsequently left the room to make phone calls. Murray testified that the period of his absence was approximately 2 minutes for a bathroom visit. The phone records presented during the trial documented a different picture. Records showed that Murray made and received multiple phone calls in the period before the 911 call, with the calls extending for significantly longer than the brief absence Murray described. The forensic medical question this creates is critical. If Murray was absent from the bedside for a period substantially longer than 2 minutes, while Michael Jackson was under propofol sedation, what does that mean for the timeline of the cardiac arrest and the response to it? The body temperature measurements taken by the coroner and the state of rigor mortis observed by paramedics and subsequently documented by the coroner provide the forensic basis for estimating the elapsed time between cardiac arrest and the initiation of resuscitation efforts. Rigor mortis, the stiffening of muscle tissue that occurs following death as ATP is depleted and actin-myosin cross-bridges become permanently formed, begins developing within 1 to 2 hours of death under normal temperature conditions, and reaches full development within 6 to 12 hours. The temperature of the environment affects this timeline, with higher temperatures accelerating the process. The paramedics who responded noted the presence of early rigor mortis in their observations. Medical examiners testified during the trial that the degree of rigor mortis present when the paramedics arrived was inconsistent with a cardiac arrest that had occurred only minutes before they were called. The forensic inference is that the cardiac arrest had occurred substantially earlier than the 911 call placed at 12:21 in the afternoon. The significance of this inference for understanding the medical events is profound. If cardiac arrest occurred significantly before resuscitation efforts began, the period of brain oxygen deprivation that would have elapsed before effective circulation was restored would have been extensive. The brain begins sustaining irreversible damage within 4 to 6 minutes of complete loss of oxygen delivery. Beyond approximately 10 minutes of total oxygen deprivation under normal temperature conditions, neurological recovery becomes essentially impossible. The chest compressions that Murray described performing after discovering Michael Jackson unresponsive were reported to have been performed on the bed rather than on a firm surface. This is medically significant because effective external cardiac compression requires a firm surface against which the sternum can be compressed. Compression performed on a mattress that flexes and absorbs the compressive force reduces the pressure generated against the heart and substantially diminishes the effectiveness of the chest compressions in generating forward blood flow. The cardiac output produced by effective CPR on a firm surface is already limited compared to normal cardiac output. CPR performed on a yielding mattress surface is substantially less effective than that. The eyelid anomaly that has generated years of public speculation is the next medical finding to examine. When the paramedics arrived and when the subsequent forensic examination was conducted, observations were made about the state of Michael Jackson's eyes. The detail has been widely discussed without the physiological framework that explains it. The mechanism of eyelid closure in living humans depends on the orbicularis oculi muscle, a circular muscle that surrounds the orbital region and controls eyelid movement. In the living state, this muscle maintains a low level of continuous tone that keeps the eyelids gently closed during rest and sleep. The facial nerve provides the neural signal that maintains this muscle tone. When the facial nerve ceases to function, as occurs at death when neural activity throughout the body stops, the orbicularis oculi loses its maintained tone. Counterintuitively, the loss of orbicularis oculi tone does not reliably produce eyelid closure. The upper eyelid is maintained in the open position by the levator palpebrae superioris muscle, which, when tonically active, holds the eye open and falls closed when this muscle relaxes. In the state of primary flaccidity that immediately follows cardiac arrest, when all muscle tone is lost simultaneously, the position the eyelid assumes depends on which mechanical forces dominate in the absence of active muscle control. In many individuals, the anatomy of the orbital region and the specific distribution of orbital fat and eyelid tissue results in the eyelid falling to a partially open position when all muscle tone is lost. This phenomenon is called logophthalmos in the medical literature, derived from the Greek word for hair, a reference to the ancient observation that hares appeared to sleep with eyes open. Logophthalmos following death is not an unusual finding. Studies examining post-mortem eye state have found rates of partial or complete eyelid opening well above 50% in some examined populations. Propofol specifically is relevant here because it produces generalized muscle relaxation as part of its mechanism of action. During propofol-induced anesthesia, the orbicularis oculi relaxes along with other muscles throughout the body. This is the reason that anesthesiologists routinely tape patients' eyelids closed during surgical procedures, because the propofol itself opens the eyes rather than closing them. In this specific situation of acute propofol intoxication progressing to cardiac arrest, the sequence begins with propofol-induced muscle relaxation across the body, including the facial muscles, controlling eyelid position, but followed by the primary flaccidity of cardiac arrest, which removes all remaining muscle tone. The eyelids that were already opened by the propofol's muscle relaxant effects would remain in that position through the transition from drug-induced sedation to postmortem state, because no mechanism for increasing muscle tone is available at any point in the sequence. The forensic documentation does not contain a formal specific finding about eyelid state as an anomalous observation requiring explanation. The absence of such a notation in the autopsy report is itself forensically informative. Forensic pathologists document observations that are clinically significant or anomalous. Open eyes after death are common enough in forensic examination that they do not typically require specific documentation as an anomalous finding. The absence of a formal notation is consistent with the medical examiners having observed a commonly encountered postmortem finding rather than something unusual. The corneal changes that occur following death provide additional forensic information. The cornea, the transparent covering of the front of the eye, is maintained in its normal clarity by continuous renewal of the tear film that lubricates and nourishes it. Following death, this renewal ceases. If the eye is open, the cornea is exposed to air and begins to develop a visible haziness or cloudiness as it dries. The rate of this change depends on the ambient temperature, humidity, and the degree to which the eye is open. Forensic pathologists use the state of the cornea as one indicator of postmortem interval and of whether the eye was open or closed during the postmortem period. The skin changes, documented in the autopsy report, provide another dimension of forensic anomaly that the official cause of death does not fully explain to a lay audience, but that is medically coherent. The autopsy documented vitiligo, affecting a significant proportion of the skin surface. Vitiligo is an autoimmune condition in which the immune system attacks and destroys the melanocytes, responsible for producing skin pigmentation. The patches of depigmented skin documented in the autopsy represent the end stage of a progressive autoimmune process that Michael Jackson had been publicly describing since the 1980s and that his treating physicians had documented with biopsy confirmation. The presence of vitiligo in the autopsy documentation is medically significant, not because it contributed to the cause of death, but because it definitively confirms the medical reality of a condition that had been widely misrepresented in public discourse for decades. The tabloid narrative that the visible skin changes across Michael Jackson's life represented deliberate bleaching rather than the progression of a documented autoimmune disease is directly contradicted by the official forensic record. The lupus documentation in the autopsy adds another layer to the medical picture. Discoid lupus erythematosus, the form documented in the forensic record, is a cutaneous autoimmune condition that produces inflammation and scarring primarily affecting the face and scalp. It creates sensitivity to ultraviolet light and causes the skin in affected areas to become fragile and prone to photo damage. The medical management of discoid lupus appropriately includes avoidance of sun exposure and protection of the affected skin from direct sunlight. This medical documentation provides the clinical context for behavioral patterns that were extensively reported as evidence of eccentricity throughout Michael Jackson's public life. The use of an umbrella to shield from sunlight, protective clothing in warm weather, and masks covering facial skin are all rational responses to the specific medical conditions documented in the forensic record, rather than expressions of psychological dysfunction. The weight finding in the autopsy is among the most clinically significant anomalies in the formal record when considered alongside the documented activity level from the This Is It rehearsals. The autopsy documented a body weight of 136 pounds at a height of 5 feet 10 inches. The body mass index this produces falls in the underweight range. The stomach contents at the time of the autopsy were documented as essentially empty of solid food. The caloric demands of the rehearsal schedule being maintained in the weeks before death were substantial. Professional level performance rehearsal for multiple hours daily requires significant energy expenditure. The metabolic demands of maintaining body heat, tissue repair, wounded and basic organ function at the documented body weight require caloric intake that the stomach documentation suggests was not being met. The combination of high activity demand and inadequate nutritional intake creates a physiological situation of chronic energy deficit that has consequences for every organ system in the body, including cardiac muscle. Cardiac muscle requires adequate energy substrate and adequate nutrition to maintain the cellular machinery that enables rhythmic contraction. Chronic nutritional deficiency affects the structural integrity of cardiac muscle cells, the availability of the energy compounds that power each contraction, and the function of the ion channels that regulate the electrical activity coordinating each heartbeat. The heart that has been operating under chronic nutritional insufficiency is a heart that is more vulnerable to acute insults than one that has been adequately nourished. This context does not change the official cause of death, which remains acute propofol intoxication. What it adds is a more complete physiological picture of the body in which the propofol-induced cardiac arrest occurred. A heart that has been chronically nutritionally stressed is a heart with reduced reserves for managing an acute pharmacological insult. The forensic picture is of a body that had been operating under multiple forms of physiological stress for an extended period before the specific event of June 25, 2009. The medications documented in the toxicology report beyond propofol and the benzodiazepines included lidocaine. Lidocaine is a local anesthetic that is sometimes combined with propofol during administration because propofol itself causes a burning or stinging sensation at the intravenous injection site. The practice of mixing lidocaine with propofol prior to injection or administering it ahead of the propofol to reduce injection discomfort is documented in the anesthesia literature. Its presence in the toxicology is consistent with Murray's described method of propofol administration. Lidocaine at higher concentrations has cardiovascular effects, including reduction of cardiac conduction velocity. The therapeutic use of lidocaine in cardiac medicine exploits this property to manage certain types of cardiac arrhythmia. At the concentrations present in Michael Jackson's system, the lidocaine was not at a level that would independently produce cardiac compromise. But the question of whether it contributed in any way to the specific cardiac events of June 25th was examined during the trial proceedings. The timeline reconstruction that the forensic evidence supports produces a medical narrative that is more complete than the public discussion of this case has typically presented. Michael Jackson was under propofol sedation, which produced generalized muscle relaxation, including relaxation of the eyelid muscles, while also suppressing respiratory drive. He was in a bedroom without monitoring equipment capable of detecting respiratory compromise. The physician responsible for his care was absent from the bedside for a period substantially longer than the brief absence he described. Respiratory depression progressed to respiratory arrest, and then to cardiac arrest, in the absence of any monitoring or immediate intervention. Some period elapsed before the cardiac arrest was discovered, during which rigor mortis had begun to develop. Resuscitation efforts were compromised by the surface on which they were performed. Emergency services were not immediately contacted. The delay between cardiac arrest and the arrival of trained emergency personnel with appropriate equipment extended beyond the window in which meaningful neurological recovery was physiologically possible. The medical anomalies that surround these final moments are not mysterious in any forensic sense. They are the predictable consequences of specific pharmacological actions, specific physiological states, and specific failures of medical care. The propofol opened the eyelids as it relaxed the orbicularis oculi. The primary flaccidity of cardiac arrest maintained that eyelid state. The rigor mortis observed by paramedics reflected the elapsed time since cardiac arrest. The toxicology documented the specific combination of agents that produced the respiratory depression that caused the cardiac arrest. What the forensic record does not contain is evidence of any event or mechanism beyond the documented pharmacological and physiological sequence. The mythology that has accumulated around the specific details of Michael Jackson's final moments does not have a forensic foundation. The details that have been treated as mysterious have medical explanations that are consistent with the documented evidence and consistent with well-established physiology. Michael Jackson died because a physician responsible for his care made specific decisions that deviated from the most basic requirements of medical practice for the substances being administered. He administered a surgical anesthetic in a private bedroom without the monitoring equipment or the emergency response capacity that the drug requires. He left his patient unattended during the period of maximum pharmacological risk. He delayed contacting emergency services after discovering his patient had ceased breathing. The forensic record documents each of these failures with the clinical precision appropriate to a formal investigation. The medical anomalies of his final moments are not anomalies in the sense of requiring explanation beyond established science. They are medically coherent consequences of documented events: the open eyes, the elevated rigor mortis, the specific toxicology profile, the weight and nutrition status. Each one makes sense within the physiological framework of what the forensic evidence establishes. What does not make sense is a system of professional medical care that allowed a physician with no anesthesia training to administer a surgical anesthetic to a patient in a private bedroom without any of the standard safety infrastructure that exists specifically to prevent the outcome that occurred on June 25, 2009. The forensic record closes the mystery. What it opens is a different and more important question. Not what happened in those final hours, because the evidence answers that with sufficient clarity, but how the circumstances that made those final hours possible were allowed to develop across the preceding months without the intervention that should have been triggered by the visible signs of physiological crisis that multiple people with proximity to Michael Jackson observed and documented. The evidence is in the record. The forensic analysis produces a coherent picture. The accountability that the criminal proceedings delivered addresses one dimension of what happened. The broader questions about the systems and circumstances that converge to produce that June afternoon remain worth examining with the same precision and the same commitment to evidence over mythology that the forensic record itself demands. He deserved better medical care. The forensic science confirms that he did not receive it. Both of those things are true simultaneously, and both of them matter.